So now it's my pleasure to introduce my co-chair, Dr. Joost van der Maaten. Dr. van der Maaten is an adult and congenital cardiac anesthesiologist in Groningen, Netherlands. He has been since a long time member of the congenital and the echocardiography subcommittee of EACTAIC, and today he's going to give a lecture about the superior cavopulmonary connection, its physiology, limitations, and anesthetic implications. Thank you very much, Joost, please.
Mona, thank you very much for this introduction. And it was a pleasure listening to your lecture, Professor Asfour. But let's continue. The superior cavopulmonary connection is also known as the bidirectional cavopulmonary shunt, or the Glenn shunt. And as you can see, it's a connection of the superior caval vein to usually the right pulmonary artery, with disconnection of the superior caval vein to the atrium, and usually closure of a pulmonary artery connection to the right ventricle. But there are several varieties within this connection. The classic Glenn, which was first performed in 58, if I'm correct, was an unidirectional Glenn, and actually that is rarely performed anymore because of the formation of unilateral malformations. The Hemi-Fontan procedure, as is sometimes called, is a connection between the right atrium and the right pulmonary artery, with a patch in the right atrium for connection of the inferior caval vein during the completion of the Fontan circulation. Then there are patients who have a bilateral cavopulmonary connection with a persistent left superior caval vein, which can be occluded if there is a good connection through the anonymous vein. Otherwise, it has to be anastomosed to the left pulmonary artery. And finally, there is a specific condition, which is the interrupted inferior vena cava, where the hepatic veins directly enter the right atrium, and where there is a hemiazygos continuation that diverts the blood towards the lungs. So, in short, for patients going towards a single ventricle solution, this is an intermediate stage in the palliation of the single ventricle patients. It's normally performed at the age of 3 to 6 months of age, and its aim is very clear. First of all, it has to increase the effective pulmonary blood flow, and secondary, it will cause ventricular remodeling because it reduces the ventricular volume. However, in the long term, after superior caval pulmonary connection, there are a lot of disadvantages. When the child grows, there is progressively less efficient for the oxygen delivery, especially during exercise. Cyanosis increases. There is the occurrence of pulmonary arteriovenous malformations because blood bypasses the alveolar beds. It creates an intrapulmonary right to left shunt. And because of the reduced to absent vascular tone, it will lead to inhibition of pulmonary hypoxic vasoconstrictions, which are all very delirious for this category of patients. Because of the increased shunt possibility, cerebral embolization may occur with even cerebral abscesses, and there is a so-called hepatic factor that is associated with this problem, that this hepatic factor that does not reach the lungs is not known yet. And finally, there are veno-venous collaterals, and the problem is that they are decompressing collaterals from the higher pressure in the superior caval connection to the lower pressure in the pulmonary veins or the inferior vena cava. This creates a physiological right to left shunt with a lot of problems like pleural effusions due to lymph collaterals. And of course, there are aortopulmonary shunts that they can be seen in other category of patients. So what is the task actually before the completion towards before the correction towards the superior caval vein. It is the only phase between stage 1 and stage 2 where the pulmonary artery, which has to grow, can catch up its growth. And it is a delicate task for the pediatric cardiologist to accomplish this result.